Hey guys, welcome back to my YouTube video channel. I am so super excited and honored to have Dr. Barry Glassman, the legendary in pain management for TMJ, sleep management. And so before I started, I just want to welcome Dr. Glassman on my show. Dr. Glassman, thank you for joining the podcast today. I'm very honored to have you here.
Oh, well, that's just it's very sweet of you, and certainly overstated. What? How do you pronounce your name?
Lock, Lock, first name Lock. Yeah, Lock, or
Locke.
you, yeah,
Okay,
Lock, yeah,
great,
yeah,
great. Thanks, Locke.
yeah. And so, Dr. Glassman, before I introduce you, I just want to let you know that we graduated the same University of Pittsburgh, Pennsylvania Dental School. And the year that you
Probably at least 2 or 3 years apart, I would assume, right?
the a year after you graduate, that's the year where I was born. So I'll let the people do some research about that and find out exactly.
Excuse me.
That is so amazing.
Well, it's amazing to you and painful to me, but it's okay.
It's a journey that I watched. I before the show I told you that when I graduated like 20 years ago, and every CE class in San Francisco, San Diego, your name pop up, and I say, okay, I'm gonna do it. I'm gonna do it. But then when I see your name is everywhere, I get nervous. I'm like, maybe he got too much information. I don't think I can take it. So I couldn't. I didn't do it. I didn't make it. But that's the reason why I searched you back, and I'm so happy that you accepted my invitation to the show. Let me just quickly, guys, just to introduce Dr. Glassman. See, he is the diplomat of American Board of Craniofacial Pain, diplomat of American Academy of Pain Management, diplomat of American Board of Sleep Medicine, and the fellow of International College of Cranial Mandibular Disorder. And he also on the board of multiple company research and publication in dentistry. So I'm just so honored to have somebody that practicing more than 4 decades be on the show, gave us the wisdom, the knowledge, the experience that there's nowhere that you can get it. So, Dr. Glassman, first of all, before I started, I want to ask you, after you graduate from dental school, how many years did you decided you get involved with these specifically the topic that most dentists don't want to touch?
Yeah, and we'll talk about that. I think
Yeah.
that's really that, rather than talking about the details of spinal fluid tract transmission and trigeminal signaling in pain, I think it's really for a general dental audience. There's so much more to understand how skewed our education is, and how the things that shouldn't scare us do because of some of the real bad information. What is it, Locke? What is it that scares us most?
People, as soon as they hear like when they see the patient with joint pain, they go like, you know what, I'm done. You done.
So what scares us most is that which we don't understand.
The diagnose, they don't.
That which we don't understand. If we don't understand it, there's no direct relationship between the severity of the problem and the severity of the pain. So you can wake up in the morning and stub your toe, hurts like hell, but you're not worried about it, right? But when you get to be my age, there are many friends of mine who have minor things wrong. They go see the doc, they do some exploratory surgery, they don't have many symptoms, and they're told what? You've got significant pancreatic cancer, you've got something, and you've got 6 months to get your act together. So there's no so if a patient comes into us with severe joint pain or less severe and whatever joint related, pain related, that's what we call non-odontogenic. It's clearly not from a tooth. And we've all seen that. We've all seen patients with good looking bicuspids with bicuspid pain. Where the gums look great and the teeth look great, and you think our first tendency is to think that this patient's nuts. I mean, this patient's
Sure.
crazy. There's nothing wrong with his tooth, and the
Yes.
patient swears, well, they're not making it up, and that this is how I got involved in pain management, because I realized that there were these people and they weren't, and I believed them, and the problem was that I couldn't find it. So, but I still didn't recognize that it could be non-odontogenic that was leading to a pain pattern that I didn't understand. And dentistry, unfortunately, Locke, carries with it in its education something that harms us all of us.
Yeah, I see.
We're taught, and we can probably name some of the professors that was Dr. Guevara still there when you were there, Pete?
Probably my friend, probably no. I don't remember his
He's wonderful. I only remember 3 names, and they're all great. But because the other names I have done what you've done. I've buried them, and because they give me nightmares. And our dental education teaches us something that is that's not realistic. It teaches us about perfection. We're taught to be perfect.
Right.
And perfection's not real. And most of the dentists that I found that were coming to take my course, were those who have overcome the fear that you just talked about. Why am I going to go there? I'm going to learn about something I don't know anything about. Overcome that fear, and it's worth it to them. Why? Because their thought is, maybe I can change my practice. Maybe I can do what Barry did.
Right.
Maybe I can put down the handpiece. Maybe I can teach. Maybe I can have a pain practice. Maybe I can have a sleep only practice.
Yeah.
Wouldn't that be, I wouldn't have to drill another tooth for the rest of my life.
Right.
Wouldn't that be wonderful? And the reality is that what we've learned is that there's a reason that burnout occurs so young, to such a young age for so many dentists, and that people are inherently, and they can't admit it to themselves, but they're inherently unhappy. They're unhappy because you're going to be unhappy if you're striving for a goal.
Right.
Sorry. If you're striving for a goal that's unreachable. You know, if you're 5'9" white and you can't jump, and your goal is to dunk a basketball, you're going to be frustrated.
Right.
So we've got an entire profession that's dealing with their awareness of their lack of, and yet who can they admit it? I'm sorry. To whom can they admit it? They can't. If they don't turn to their staff and say, well, today we did 14 procedures. 4 of them were A's, 3 were B's, 4 were C minuses. I didn't get the contacts right. I didn't, no, we don't do that. So, but who knows it? We don't go home to our wives and say, well, today I did 2 B's, 4 C's, and an F. We don't do that.
Right.
But we know it.
Right. Inside my out.
We know it. So how do we deal with that? Our goal was, we didn't want to do the F. We didn't want to screw up that procedure.
Yeah.
So, and it probably wasn't our fault. Things happen. It's a tough profession.
Exactly.
Physicians don't prescribe Topamax for a headache patient. And 2 weeks later, when they come back and the patient says, well, my headaches are worse and I'm numb and I can't remember my name and my fingers are numb, my feet are numb, the physician doesn't get in the car and beat himself up because the headaches didn't go away. But when the crown doesn't fit for the 3rd time, the dentist does. and it starts to beat you. It starts to beat at us.
Right.
We either become numb to it by protecting ourselves and developing a shield, or internally it beats us, and we're don't love the practice the way we wanted to love it, and it begins to affect us as a father.
Right.
It begins to affect us as a husband or a wife, as a spouse.
It is true.
Yeah, it begins to affect, and we don't know why we're not happy. We're not happy because we're not making enough money. We're not happy because we don't have enough new patients. We're not happy because we have to deal with so many hormones on our staff, issues. We don't, we blame everything.
Mm-hmm.
We don't understand that we're not happy
Mhm.
because we've set goals for ourselves that are unreachable.
Mm-hmm.
And we were actually taught that they're not only reachable, but that's what was expected of us every day on every patient.
Right, right. We have high expectation for our profession. We are all the perfectionist people.
We're
Yeah.
perfectionists, and we're perfection beyond what I call clinical significance.
Mm, mm,
So some of the things that upset us aren't really the kinds of things that clinically make any difference whatsoever.
right.
But it really, how close does a margin have to be in order to be successful? I thought I was a really good dentist until I did what? Until I bought loops.
Right, right, right. Exactly.
So I sold them.
That's right. So guys, just to let you know that before we go into this show, Dr. Barry and me, we mentioned that we both are under the weather today, but we since we set up the time, so we go ahead and just continue our conversation. So we just want to make
I
sure you guys
apologize
understand that we have little issue with our voice, myself, Dr. Glassman as well. So thank you for bearing with us. So Dr. Glassman, what you were mentioned was most likely more like related to occlusion. So can you give us a little bit of tip about how do you believe that occlusion can cause TMJ or TMJ can cause occlusion, or it correlated, or what are the kind of relationship that we have with TMJ and occlusion?
It's probably the number one myth that we try to break and help people with.
Okay.
And that's what we call the stipulation of occlusion.
Mm-hmm.
Teeth actually don't contact in maximum intercuspation in function. So there's never a time that during function, which is eating, swallowing, talking, during function, breathing, during function, our teeth don't touch. So when is it that this occlusion matters? Occlusion is a noun. Occluding is a verb.
Mm-hmm. Mm-hmm.
Nouns don't hurt us. This doesn't hurt.
Right, right.
Until what? Until I start banging.
Mm-hmm.
Then it hurts.
Mm-hmm.
So the noun doesn't hurt us, the verb does. We stipulate occlusion. If I were to give you an upper and a lower model, it's the first thing you would do. Let's check how good the bite is.
Mm-hmm.
Right. And what you're really saying is, let's look and see what happens when the masseter and temporalis go into permanent contraction and stay that way, even though it never happens in function.
Mm-hmm.
So why is it? So why is it so important? Why is that important?
Mm-hmm.
Well, it happens in parafunction. It happens when people are grinding or clenching their teeth. Agreed.
Mm-hmm.
Is that normal? Does everyone do it? Well, sorry.
Mm-hmm.
It turns out more people do it than we thought. And yet, interestingly enough, there is no direct relationship between the amount that somebody does it and the amount of pain they have or don't have. So when you say, is there a cause?
Mm-hmm.
Occlusion doesn't cause anything. Occluding parafunction can be a contributing factor based upon the forces that occur during parafunction in the system, and the patient's adaptive capacity. So there are some people who can grind and clench a lot and have no signs and symptoms, and other people can grind and clench a little, and it can contribute to significant signs and symptoms.
Yep.
But it's not whether it's Angles class 1. There's no relationship of pain to anything.
Okay.
That's one. It's not whether it's deep bite. The old theory was if you have deep bite, then your condyles are up and back. That's just not true.
Mm.
It's not that the condyles are clenching in or grinding into the retrodiscal tissue the way we were taught. That doesn't happen. And when we show that in our courses, how that the forces don't allow that to happen. So there is a lot of things that we're taught. So I often say occlusion doesn't matter unless you're occluding. And people don't hear that. And they say that, don't go to Glassman, he's nuts. I mean, he'll tell you occlusion doesn't matter. Now, we've all adjusted teeth on someone that was sore and they came back 2 days later and said, that was great, Dr. Locke, thank you.
Mhm.
Yeah. So you're trying to tell me occlusion doesn't matter? I said, I would never say that.
Okay.
Of course it can.
Mm-hmm.
But when and on whom and in what perspective and what and understanding why that there are some people who have worn down teeth and feel great,
Mm-hmm.
and some people who don't have any wear patterns at all, and yet their occlusion is playing a role in the strain or sprain of their temporomandibular joints.
So I have two things. So one is you mentioned about class 1, class 2, class 3, and so in what you what you were saying is would the orthodontist treatment for an ideal class 1 occlusion matter much in terms of the TMJ, the TMD patient, or it doesn't matter?
It's absolutely, it doesn't matter.
Sure.
It literally doesn't.
Thank you for calling Civic Theater. To reach the box office for
Sorry, my watch is calling. No, it literally doesn't matter. There is no.
Dr. Glassman, there is one person, Kayla Glass. Is that your one of your people that you invite? Is her name? Somebody called Kayla Glass want to join. I don't know how to get that information, but
I don't know her. I don't know her, but
right.
whatever it's your call.
No, I don't know this person. Yeah, so I'm gonna click no. Yep.
Okay.
Yeah.
There's been no relationship between class 1 and class 2 and class 3 in terms of pain, nor in terms of sleep disorders, by the way.
Okay. Wow. Wow. Sleep disorder either. Wow.
You would think everyone says, well, that retruded mandible
Mm-hmm.
is what's causing it. Well, it turns out that sleep disorders are a combination of anatomy issues, but also physiology.
Mm-hmm.
Those people that have retruded mandibles don't have any trouble breathing during the day, right?
Mm-hmm. Right.
No one's no who's got how many people snore? How many people snore during the day? No,
Right.
or have apnea during the day. So it's an altered physiology. There are people with very narrow airways that don't have apnea. There are people with very wide areas whose airways collapse.
Wow, that is interesting. Thank you for clarifying that.
So they're looking. So orthodontists are often held, I think, to the wrong standards. And here's a question. Imagine this situation. A patient walks into your office. She's 14 years old. She just got her bands off. She's in nice class 1, and you'll notice that the mesiobuccal cusp is not in occlusion on the left side. And the patient says to you, Dr. Locke, ever since they took the bands off, my jaw joint is clicking, which happens quite a bit after bands come off. So now and she says, what should I do? And you go, like most dentists would go, oh, well, there's some issues with your orthodontics. You should go back to the orthodontist. But what message did you just give her? That the orthodontics wasn't done right, and that's caused her clicking. And you can put that mesiobuccal cusp in the fossa all you want. That clicking is not going to go away.
Right.
That's not what caused it. So that's something that a general dentist should be able to handle extremely well.
Okay.
And that's what we teach in our 2-day course.
Okay. Wonderful. And then the other thing you were talking about was the physiology, the muscle related. What about the emotional or psychological? Is that the stress level of a that person? Is that also a factor that contribute to the bruxism, the grinding, the TMD issue?
We have every reason. So some really excellent work has shown that people who tend to grind or clench will tend to grind or clench more during stressful periods. So there's no question that there seems to be a relationship. That doesn't mean, again, that there's a direct relationship between that amount of grinding and clenching and the pain or dysfunction, but it can make a difference. It can be the triggering factor for some patients. The psychological, the whole issue of the psychosocial model and the role of the psychological and social issues play in pain management really makes what we do very, very special and important, because you need to spend time and hear and listen to your patient in a different way than you need to as a general dentist. And so there are some things that general dentists can do and do well, but even those, we need to change the way we communicate. And so patient relations and listening to patients, the first visit, we teach that, I'm a firm believer in this, that the first time you see a patient, Locke, should never be in a dental chair. Never.
Wow.
Because let's think about this. Let's think about this for a second. What's your goal? What's the goal of the first visit? A new patients come, they found out about Dr. Locke. They drove past 18 dental offices, right?
Yeah.
Probably you're in a crowded area. You drove past 18 areas, the offices, to find your office, to walk in and see you. What is your goal with that patient? Now, I get lots of answers when I ask dentists that question. The most common answer is, my goal is to introduce myself, make them comfortable in my office, get as many records as I can, all the records that I need, so that I am prepared next time when they come to sit down and give them a consultation.
My goal is probably like a chief complaint, find out the chief complaint first.
And in this case, this chief complaint is none. I've just moved to the area. I need a new dentist.
Okay, yeah.
Now what's your goal?
Getting to know them and see how we can build the report and how we can help them.
That's a great answer. It's a great answer. It's not common. Okay. How do you know whether or not your appointment was successful? And here's what I say to that. If I could be a fly on the wall in the living room or in the dining room that night, when that female patient sits down with her husband and her husband says, "So you went to see that new dentist today. Tell me how it went." If I could hear the answer, I can tell you, one, am I going to be successful with this patient? Is this patient going to be a pain in the ass? Is this patient going to be good to work with? Am I going to be, how do we move in the right direction to have a relationship that we've set appropriate expectations to do the best therapy for her?
Right.
And how do we do that? We don't do that by saying, "Hi, I'm Dr. Glassman. Nice to meet you. Open."
Right.
We don't do that.
Right.
So we tell everyone that that first visit should be in a non-dental setting. Your office, a consultation room, where I need any kind of thing, and you introduce yourself, you make some contact with a handshake, or and you sit down. And your first question, it takes 3 minutes to do this. It's the best 3 minutes you'll ever spend. And if your first question is about that patient, now you've done something that no one else has ever done, and that is you've actually read their record. So you don't say to them, are you on any medication?
Mhm.
Because you just, how much does that piss you off when you're a patient?
Right,
You just wrote down all the drugs, and then the guy walks in and says, are you on any medication? Well, I
right,
do all that,
right.
right? And don't think the patient, and as soon as you show the patient that they aren't just a patient, but are a human, you've given them value as a human.
Right.
So you're a dentist. You went to Pitt. My goodness, I bet we had some of the, I know it's a long time ago, but I had some instructors. Do you remember any of your teachers' names? I'm not kidding. That would be my first question.
Right,
Right.
right.
So is there anything here you're here for specifically? Is there any problems that you're having? Have you ever had any problems in a dental office?
Mhm.
After I went through the next thing I would, after that first question, the next question would be, so I see you're on Lodipine for high blood pressure. How long have you been on that? And what does that say to her?
Mhm.
It says you read the record.
Mhm.
They don't, nobody expects that.
Right,
Nobody does.
right.
Name an internist that does.
Mhm.
Mine didn't when I moved down here to Florida. I wanted to take my fingers and my hands and wrap it around his neck. But I couldn't see his face because his head was in a computer.
Right, right.
No. And then we go down and all of a sudden the world has changed.
Mhm.
The world has changed because you've done something that no one else does. You've
Mhm.
expressed some interest in her as a human. You've given quality to her. And you've treated her not as we don't even like to use the word patient in our office.
Mhm.
You've treated her
At a person, yeah.
as a human,
Mhm. Yeah.
Yeah. And as soon as you put a bib on somebody and you lie them down, I don't care where, everyone becomes the same. They become a masseter and a temporalis, a maxilla and a mandible and teeth.
Mm. Beautiful. Yes, I agree with you. We have to focus on chip complaint, focus on the personality, the emotional, the whole aspect of a overall human body, mouth and body connection. Find out everything before we start the going deeper on their diagnosis.
Good restaurants, walked in and what's the first thing they ask you? Anyone here with any allergies?
Hmm.
Oh, you do? What are they? Boom, 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 right there. I'll talk to my chef.
Mhm.
Yeah.
Right.
It doesn't happen at McDonald's, but it just, but good restaurant.
Right. Exactly. Yeah. So, Dr. Glassman, about the appliance, various of dental appliance for sleep patient, are these appliance work, or are they some of them doesn't work, or are there limitation for what we can do for those? Like, let's just focus on the grinder, people who have a bruxism grinding. Would you do combine appliance and medication and muscle therapy, or what are those things that you do?
Okay, so like any medical disorder,
Mhm.
we don't treat bruxism per se because bruxism isn't a disorder, right? Bruxism is not a disorder.
Okay.
What causes bruxism? And
Muscle, I don't know.
yeah, the answer, that's, you don't, Locke, you have no idea
Mhm.
how brilliant your answer was. So that's a brilliant answer.
Mhm.
Those, I often teach that the three hardest words
Mhm.
for men to say who are male dentists isn't "I love you," but it's "I don't know." And and the reality is that we've made stuff up. In 1960, Ranford and Ash literally made up with a study of 9 patients and no control group, that bruxism was caused by quote unquote occlusal interferences. And it's remained in our vernacular and our teachings amongst many of our restorative gurus, continues today. And there's never been any evidence of that.
Yeah.
In fact, there's been evidence. Goodman did studies with mock equilibrations and showed equal effect. that in reality it's not occlusion. The way the teeth occlude doesn't cause the muscles to suddenly contract for no good reason at night. So we know now that bruxism is centrally mediated. It's nothing peripheral. We have reason either we go through some work that was done that gives us a suspect of what that possibly bruxism played a role in growth and development when an interesting study was done where they eliminated the ability of rats with snouts to brux and grind in the neonatal stage. And when they did that, the condyle actually ankylosed to the fossa. So we have reason to believe that there's a developmental advantage in growth and development of this biphasic muscular activity that disappear, that we lose its need, but we may be it may be just left over for some of our adults, and some of our adults in fact grind and clench and have an adaptive capacity that doesn't affect anything negatively, and some of us are affected severely by the grinding and clenching. So the question is, we don't treat bruxism until we have a disorder that needs to be treated. So what are some of the disorders? Well, first thing, it can cause occlusal wear. I don't really care much about occlusal wear. That's my patient does. There's a group out in California that you may be familiar with, and Pete was teaching it too. And that was a disease called occlusal disease. There is no such thing. That's just, that's
Okay.
That's like, if a car rams into a tree and the fender bends, you're calling that car's got fender disease. No, the fender, of course it bends. It ran into a tree.
Right.
It's not an occlusal. I don't have to treat the teeth. My goodness.
So yeah, please continue. And I want to ask you, like, the occlusion, what you see on the occlusion wearing and the condyle and at the joint, is this really you see the evidence of wear and tear of the TMJ and also the grinding?
It's a really good question. Okay, and I'll try to do this as briefly as I can. What you're asking is a really good question. What do we see in as effects of bruxism from zero, because we can see zero, to we can see specific wear patterns, whether they be lock and key patterns when we move a patient laterally. Just keep this in mind. When you tell a patient close, slide to the left, all right, when is it that the patient does that?
When is it?
Yes. When in life do they do that? Do they do that when they're talking?
No.
No. Do they do that when they're kissing their spouse? No. Do they do that when they're eating?
Maybe a little.
No.
No.
That's an inside out move. You don't do that. See, this is kind of interesting, and let me just make this clear. This isn't our fault. Right? This isn't our fault. This happened to me, my wife, and I was probably about your age, and I had put a 5-unit bridge in a patient. And I'm one of these people, as you could probably tell, that's got my heart on my sleeve, and my wife knows everything about me and everything about my practice, and knew I was unhappy, didn't know why. But wake up one morning and she said, something's bothering you. Yeah, I said, yeah. What is it? I said, put this 5-unit bridge in this patient. And she has an interesting complaint. She said she's not chewing as efficiently as she was before. She said, that's really fascinating. All the years, I've never heard this before. I've never had this before. Did you check the bite? And I said, yeah, of course, yeah, everything seemed fine. Well, maybe there's something deeper here. Why don't you explain to me how people chew? I said, what? So what? No, explain to me how people chew. So, you know, I said, well, you know, you take the food and you open, put the food in, and then you go, no. Tell me about the muscles and the neurology. Where's that all happen? Where's that all? You know, is something? Could something have gone wrong? Where's? And I looked at her. I said, I don't know. She said, you don't, do you? I said, no. She said, I don't know how to tell you this, but I wouldn't want to go to a podiatrist that didn't know how I walked. And it suddenly struck me that we're, so if I talk to you about masticatory cycles, if I talk to you about the functional generative path, if I talk to you about 19 to 21 millimeters of an elliptical pattern that wasn't related to teeth, to cusp, whether you were cows or pigs, our whole masticatory pattern, you'd be blown away.
Mm-hmm.
We talked about when do teeth touch and where do they touch with a bolus. Has nothing to do with where they touch when we put articulating paper in somebody's mouth.
Mm-hmm.
So what happened? Well, we now know what happened.
Mm-hmm.
We teach what happened. We know how to fix that or how to deal with that, because the answer is do nothing and the body will adapt. But that's not the point. Is that we're not taught those kinds of things. We're taught slide to the left, slide to the right, immediate exclusion, anterior guidance, and we're not taught that it doesn't happen during function. It only happens during parafunction.
Parafunction, right? Mm-hmm.
It's the only time that happens. And you know, and then when people you put a patient, you say, ever have this lock? You say, all right, close, and then slide to the left, and the patient can't go.
Mm-hmm.
And you, oh, their teeth have them locked in. They're locked in. Their teeth aren't locked in. What are you asking the patient to do? What you're asking the patient to do is, what I want you to do is I want you to contract your masseter and your temporalis and your medial tergoid. Contract. All right. Now what I want you to do is to slightly release your masseter, temporalis, and medial tergoid, but still maintain contact, and then rhythmically contract your lateral tergoids left and right to create grinding. Go. Now, you know, obviously that's not what so if the patient doesn't know to release their masseter and temporalis to allow that to happen, they feel like they're locked in.
Mm-hmm.
If you took a tongue blade and you put it between the teeth, and now the masseter and temporalis can't contract, and you say, now slide to the left, whoop, they'll go.
Mm-hmm.
Nothing to do with the fact. And then so in those situations, if you just walk up to the patient and you put your hands on their muscle, on their, I said, on mine, I say, here, give me your hands. I put them on my face.
Mm-hmm.
And I slide. I said, now put them on your face.
Mm-hmm.
Do that. They do it.
Mm-hmm.
They've figured out.
Mm-hmm.
Oh, that's what you want.
Mm-hmm.
So teeth, we tend to give, because we're dentists,
Mm-hmm.
we tend to make teeth the king of the craniomandibular cervical system.
Mm-hmm.
They're not the kings. They're an important part of the system,
Right.
an integral part of the system.
Right.
But they don't rule the system because we're the dentists. And suddenly when they go to a chiropractor, now it's the vertebrae that rule the system. And now suddenly when they go to a neurologist, it's the neurology that rules the system. No, it's the same system. And it's not that hard to learn. And what we do is we give dentists ways to understand, to set proper expectations when it comes to, and be able to help the number of people that we can help with cervicogenic headaches, with morning headaches, we teach them about joints. For example, the other place you can do damage is into a joint. And here's the good news.
Mm-hmm.
You can't do real damage to a joint. Your appliances, and what you do in the mouth, it's really, really hard to do any kind of severe damage to a joint. The joint is this condyle that I might have. Where's Oscar? So here's the condyle,
Mm-hmm.
and in this condyle,
Mm-hmm.
there's a disc, and that disc has biconcave, the 3 zones, etc. But it's got a lateral collateral ligament, a medial collateral ligament.
Mm-hmm.
Anteriorly, it's the lateral pterygoid, and posteriorly, it's a retrodiscal lamina. So it's ligament-like, but it's not a true ligament. And this tethers this disc. If there's trauma, whether it be micro trauma of bruxism or macro trauma, getting hit in the mouth,
Right.
damage is done to the system. Damage is always usually done to the weakest link of the system. The weakest link of the system is where the ligaments insert in the bone.
Right. Right.
Like the turkey bone, the weakest part. That's called the enthesis. When those are compromised, this disc becomes wobbly.
Right.
Now it's not tethered as well. And if it's tethered poorly enough, it slips out of place. Sounds terrible. It's not. 30 to 40% of your adult population has some sort of disc compromise. No signs or symptoms. And it's fine. It's fine. And this thing that dentistry got into, well, if the disc is clicking, we've got to reposition the mandible and bring the disc back over it. It's crazy. It's crazy. There are other ways to alter the forces so that those forces that are being pathological or become forces to which we can adapt. So you can do damage to the joints, or you can do damage to the teeth.
I see. So in other words, if we prescribe a patient a night guard to protect the bruxism, thing like that, is that something you still recommend in combined with other therapy?
So the problem with night guards, there are lots of problems with night guards. Night guards protect the teeth they cover.
Right.
That's all they do.
Right.
They in some cases, the use of a night guard can actually increase the forces in the joint itself. Remember that thing that we were taught in dental school? I wonder if you were still taught this. I'm sure you were. The first 20 millimeters is pure rotation, and then we start to translate.
Right. Yeah. Yes.
That's a lie, just so you know. I don't know why they do that, why they lie like that. I mean, what it just doesn't happen. When the depressors bring the jaw forward, the lateral pterygoid contracts at the same time as the suprahyoids and the supradigastric. And if the lateral pterygoid, which is origin at the lateral pterygoid process of the sphenoid bone, when it inserts on the fovea, right underneath the neck of the condyle, when it contracts, it brings the jaw forward immediately. So if you put anything between the teeth, you're bringing that jaw forward. That's why, if you remember, Locke, in the beginning, I said to you, that thing that when you clench and grind your teeth, your condyle is going back up into the fossa, and it's crushing the retrodiscal tissue. It doesn't happen. We're bringing it forward.
I see.
So the problem with night guards is that it can help some people. It can help their teeth. It can lower the forces for some. It increases the forces for others. And most night guards are made where patients don't wear them. And the number one reason they don't wear them is because they're too tight.
Too tight.
Yeah. Patients, when we send that level of afferent nociceptive information back into the trigeminal system, they become hypersensitized and uncomfortable, and yet they can't. put their finger on, it doesn't hurt a particular tooth. They don't realize that that's what's sending the messages,
Mhm.
but they know they're not comfortable, so they stop
Right.
wearing.
Right.
So if you're going to make a night guard
Mhm.
and you want to make a flat plane and you think it might help your patient, you can certainly try that. It's not our design of choice.
Mhm.
Most of the time, it is sometimes. It's not our design most of the time. But if you're going to do it, just again, it's not going anywhere. Make it so that it just comes out. So, with no drag, none.
Mhm.
There's no reason. There's nothing. You got nothing to worry about. You'll increase your compliance by a whole lot.
Yeah. But you said you mentioned it's flat. You had to make it flat surface, everything flat.
Well, the night guard.
Mhm.
I mean, in general, that's what most. Yeah, I mean, if you want to go ahead and make a tanner where you're providing canine rise and anterior guides, that's quite a job, but you can do that.
Mhm.
We're proponents for anterior midpoint stop appliances. So we'll do, a lot of people know them as NTIs. We make what I've constructed in my office for years, which Dawson learned from us and then created a concept of B splints.
Mhm.
That's from our office. And that's our appliance of choice. People say you can't use them because of all kinds of myths. The corn's anterior open bites and the teeth super erupt, which is not, the teeth don't super erupt or intrude. And studies demonstrate, Wellhouse done a good study that shows you can intrude teeth, but it gets a little more complicated. And to go through all that right now is more than, and it's very hard when you're taught that these things cause all these kinds of trouble.
Mhm.
And you can only wear them for short periods of time and you can't use them for internal derangements. I will only tell you that for 25 years, we use them and continue to use them as I consult for other practices
Mhm.
On major joint issues with high levels of success. So
Okay. One of my friend mentioned that he he prescribed the NTI for teenage, and then she disappeared for a few years, and she came back with an open bite.
yes.
And I like you, isn't it there's a age limitation that we shouldn't do NTI
No,
for
no,
growing?
I do them on 6-year-olds for migraines.
Hmm.
So we call it pediatric B splints. So no,
Okay.
it's not an age limitation.
Mm-hmm.
It is, and it's one of the things about pain management is that you need to do what's called risk benefit quotients. You got to look
Got
at
it.
the risks and you got to look at the benefits.
Okay.
You have to be a little bit more knowledgeable
Mm-hmm.
if you're talking about headache
Mm-hmm.
and looking at risks and benefits. We don't ever want to use an anterior midpoint stop appliance on an asymptomatic patient with a deep bite of less than like 2 millimeters, because interestingly enough, that you can develop, I've seen this, you can develop anterior open bites with a flat plane appliance. You are more likely to develop anterior open bites with an anterior midpoint stop appliance. And we've had some work, we had work done, we've done some work as an excellent physical therapist out of Chile by the name of Rockabato, who came to our office and did some work with us. And what we discovered was there were alterations in the trajectory. It wasn't in all of the open bite cases, and I worked with Jim Boyd for years, where I managed this. I helped him manage all the side effect cases, and in all of those cases where there's anterior open bite, if you take the models and you put it on the anterior and you put them together, the teeth fit perfectly.
Mm.
So something else has changed, and it's not condylar posture, because we've looked at corrected tomograms. And Rockabato pointed out to them on all these cases, we had an improvement in the cervical lordosis. And with that improvement in the cervical lordosis, there was an alteration in the trajectory, and the patient was actually closing differently, so that the back teeth were now touching first.
Mm.
It matters if that consequence is worse than the crime. It doesn't matter if it doesn't. And I'll tell you just a really quick story.
Mhm.
There was a 15-year-old young lady came to see us,
Mhm.
and it turned out that she had severe chronic daily migraine.
You said
And
how old is the patient?
15,
15. Wow. Okay.
15-year-old female. Mom pulls me aside in tears to let me know that I'm the last hope,
Hmm.
that they've been through neurology, they've been through everything. No one can touch her. No one
Mhm.
can help her. She's
Mhm.
had 3 attempts at suicide,
Wow.
15.
Wow.
So we see her. We decide to go ahead with anterior midpoint stop appliance therapy.
Mhm.
We did some other things with her. And it doesn't always happen, trust me.
Mhm.
But within 6 months to 8 months, she was literally headache free.
Wow.
Now, at 17, she started to develop an anterior open bite.
Hmm.
18, it got bigger. At 19, it got bigger.
Mhm.
And each time that happened, I had to keep changing the appliance to avoid posterior contact.
Yes.
So we raising the appliance. She could care less.
Hmm.
She's eating, she's fine. She's, aesthetically, anterior open bites are not a problem.
Mhm.
People think they are. I guarantee you, if you sit in the mall in front of Victoria's Secret and while your wife's shopping and you're sitting there and you're watching 500 people go by, you won't pick out one anterior open bite, because it only happens when
Mhm.
the
When-
teeth are together.
Right. Right. Right.
And it's not like they have buck teeth. They're like, no, they look fine.
Mhm.
At 19, I lose her. She goes away. I've
Mhm.
written up the case. I've got the case. I'm showing the case all over the country.
Yes.
10 years later,
Mhm.
20, she's now 29. I realized I haven't seen Shelly
Mhm.
for 10 years.
Yeah.
Turn to my staff and say, do me a favor and get Shelly in.
Mhm.
The last time I saw her, she had about a 7mm open bite.
Hmm.
They find her. She's not living but she's coming home for Christmas.
Right.
And she's, oh my God, Dr. Barry, she'd love to see you.
Hmm.
Shelly comes in during December and sits down, and I walk into the room. She's 29 years old.
Wow.
And she looks at me and says, I need to show you something.
Yeah.
She pulls out a picture of her triplets.
Wow. Okay.
And she said, Dr. Barry,
Mhm.
they wouldn't be here
Mhm.
if it weren't for you. And, we're all, it's all, and I don't like to get mama drama-ish and whatnot, but this one's special.
Mhm.
I said, okay, Michelle, that's great. Let me see. And she's got now about the same 7 to 9mm open bite. Goes great. Let me see your appliance. She said, no, I didn't bring it. I said, you didn't? I want to see it.
Mhm.
She said, yeah, I have it. I said, yeah, I can't sleep without it. So, well, why didn't you bring it?
Mhm.
Her answer, Dr. Barrett, I was afraid you learned something and you were going to take it away from me.
I see.
Now, there would be dentists that would look at that and say, oh my God, Glassman, what you did.
Hmm.
Oh, what you did. Isn't that horrible?
Hmm.
These are people who don't understand risks and
Hmm.
benefits.
Hmm. Hmm. That's right. That's right. So, Dr. Berry, when you mentioned anterior open bite, is this the anterior tip? It just flare out or just deeper bite or?
They don't use, it's not flaring because they don't affect the teeth.
Mhm.
The teeth haven't changed. The
Okay.
back teeth haven't changed.
Mhm.
It's just that, so instead of coming like so, it comes like so.
Okay.
And there's some posterior contact somewhere.
Mhm.
We did a survey of 77,000 cases. It's published,
Wow.
and found that the ill effects were noted on these by the docs that are using these appliances 1.6% of the time.
Very little.
Yeah.
The risk, the benefit is a lot more than the risk.
It can be.
Mhm.
So you're right, if there's a benefit. So if you say to me, would you use this appliance routinely for bruxism in an asymptomatic patient? I said, no, why would I do that? You're
Mm.
just trying to protect the brush, and you don't have any pain. Give him a flat plane appliance.
Okay.
there's less risk of an occlusal change.
Got it.
But it always cracks me up when the TMD experts say, "Oh my God, you can't use the appliance because it causes occlusal change," and then in the next breath they say, "But there's no relationship between TMD and occlusion." So if we're getting people better, well, you're not getting them better because you can't do good studies, unfortunately, with appliances. So what they do is they take an NTI, which I'm not a total fan of by itself. It's fine. But they take an NTI and they put it in and they don't adjust it because they don't have anybody who understands the therapeutic protocol. And in order to keep it consistent, well, no, if you don't follow the protocol, you're not going to help people.
Right.
So there's a way that we have to do it to follow. So we obviously teach the protocol.
Okay. Yeah. So that's what you need to go for the courses to really learn the diagnose the protocol. What about the people who have like a full set of upper and lower veneer? Would you still do the NTI or don't touch it?
It's a great question.
Mhm.
Not only did I do NTIs on patients with full, but if you do them on your patients, that's one thing. But I did them on your patients. So you know what I'm saying? So they're not my patient. I wasn't seeing general dental patients. So people say, "Oh, well, you're putting it, I wouldn't risk that." I said, that's pretty interesting. I'm risking it on your patient. So
Okay.
I'm kind of, so there are ways that we can make sure, where the shear forces occur, or when the forces are not in the direct long axis of the tooth. You flex that tooth and you'll crack a veneer.
Right.
Okay. You know that if you've got a patient with anterior, and they're rubbing their front teeth and at night and they're coming forward in protrusion, you're going to get some cracks on the upper veneers.
Right. Yes.
So yeah, no, we want to protect that. So we can protect it. We teach dual arch appliance therapy. So they're wearing an upper arch and a lower arch, and then it's acrylic on acrylic.
Yeah.
And it diffuses the forces.
Dr. Glassman, for the audience who watching and our podcast, can you give us the audience a message that the myth and the about occlusion and things like that? Like what would they learn from your course, those 2-day course, that they will be taken home and feel a lot more confident in their practice, and they can focus on something that more meaningful for their career?
It's a great question, Locke, and I appreciate it because I happen to think our course is, and I'm not doing this to sell course, but I'm 75, and what I have left is to give this profession is try to prevent for others the torturous path that I went through. I went through studying from Niles Gushel and Gichet and Pete Neff, and then to Pete Dawson and to Harold Gelb and to Bernie Jenkelson and neuromuscular dentistry, until somebody grabbed a hold of me and taught me about evidence and taught me about understanding. And when I realized how simple it all is, and that we spend way too much time on details of occlusion that do not tend to matter, and that the basics are really important, but that we need to learn that, keep our eye on the target of patient care, learn to use the predominance of the science to guide our art, knowing that we're still allowed to use our clinical judgment. We need to understand that occlusion doesn't matter unless we're occluding. We need to understand that joints aren't anything to be afraid of, but we can help that 17-year-old who's starting to click, and we're worried about it, or we're concerned about it. We need to be able to tell mom what's causing that, and how we can deal with that, what the odds are, and what they should watch for, so that we're not taking responsibility for that which we don't have any control. But we do have more control when we understand more about that which we weren't taught. And we're taught so many. I worked hand in hand with a really excellent prosthodontist by the name of Harold Chaslin.
Yeah.
And Howard took my course, and mine and Jim Boyd taught a course in San Diego. Oh God, 20 years ago. Yeah, about 15, 20 years ago. And since then, Howard and I have taught together. And Howard's one of those few prosthodontists who get it, who doesn't use a face bow in major cases, who understands the reality of articulators. The study of gnatology is the study of how articulators chew. Has nothing to do with teeth. The articulator has nothing to do with how a jaw functions. It's the upper mutant that moves, for God's sakes. The condyle head that doesn't move at all the way the condyle does in the fossa. Not that you shouldn't use an articulator as a restorative dentist, and not that you can't use CR if that's what you're trying to do from a restorative side. But CR and interferences have nothing to do with the development of pain. Spasms don't tend to happen. Lateral pterygoid spasms don't usually occur. If a patient had a lateral pterygoid spasm, muscle injury is overrated. Ligament and joint injury is underrated. Bruxism is a function is overrated, and parafunction is underrated. Appliance therapy, a flat plane is overrated. Optional designs are underrated. So when you gain confidence, so that you don't look, I think you'll get a kick out of this. Do you remember the name of the orthodontist we had that had his own cephalometric analysis, and it was done out of the University of Pittsburgh? Do you remember his name?
I scratched my head.
Sassooni.
Oh, yes.
So Pitt had some big names. Pitt had Sassooni. Pitt had Archer.
Yes.
In ortho and surgery. Had Bennett and Mannheim.
Yes.
In surgery and anesthesia.
Yes.
We had big names.
Yes. Including your name too.
No. I wasn't. No, I'll tell you, that's a funny story. So I don't know if we have time for that. That's a funny story. As a freshman, they sat us down in the cubicles, and the orthodontic residents came and looked at everyone's bite. And look, and now as a kid, my father was a taxi cab driver, and then he opened up his own business and began to do kind of well for himself. And his son, we moved into the suburbs of Philadelphia, but he wanted his son to have the best orthodontics. If he's going to get ortho, so we found a guy by the name of Leibowitz, who was down in another Jewish orthodontist down in downtown Philadelphia. My mom drove on the Schuylkill Expressway once a month to take me to Dr. Leibowitz to get the best ortho possible. Did a nice job. I'm sitting there, and the orthodontic resident comes over and goes, "Close." I close. He goes, "Oh, go on. Do you have ortho?" I said, "Yeah." "Oh, hey guys, everybody over here." My heart's beating. I'm a freshman in dental school. I don't know. My God, what is he going to do? What's he going to say? Look at this. This guy had ortho. And everybody, oh. I said, I'm thinking, I'm never going to eat meat again. What's he telling me? What's going on? I said, what's wrong? And not knowing the value of this, with a very stern face, he said, "Your orthodontist left your second molar in crossbite." I started to cry. I mean, how could a dentist have a second molar in crossbite? Oh my God. Then I turned to the guy next to me. He says, "What's crossbite?" How ridiculous. how totally ridiculous. And so orthodontists should not be held to the way the teeth come together, because it really doesn't matter all that much.
Okay.
It can, don't get me wrong. Orthodontists should be held to appropriate craniofacial development, growth and development in the younger ages. They shouldn't have cases with teeth in their cases to show their bites.
Mm.
They should have walls with smiles and faces. That's, as a parent, that's what I would want for my orthodontist.
Mm.
Not ideal occlusion.
Okay.
As an orthodontist, if you want to look him up by the name of Rinchhouse,
Mhm.
he's from Pittsburgh. He and his brother are from Pittsburgh. And he has written some beautiful articles on CR. There's obviously somebody at my door. Let me close that door. One second.
Hey guys, just thank you for continue watching this show. Just let you know that before we start the show, we understand that Dr. Barry Glassman is not doing well with his upper respiratory taking medication, but he's still trying to jump on our show and pretty much continue this podcast. So bear with us. We have some coughing. Eventually, we're going to be getting better. But I just want to thank you, Dr. Glassman, that you take your time, and even though you're not fully, above the water, but you do your best, and I really appreciate. And
I hope it wasn't too disturbing.
we've been on a podcast close to an hour and 15-20 minutes, so it's wonderful that you have really dedicated your time today, Dr. Glassman. You could have just take a nap, but you did it for me, and it's just something I really I'm honored and appreciate the time that you are here today, and I can't wait. Maybe in the future we're gonna start another topic more particularly focus on one thing, but today I learned a lot from you, Dr. Glassman. We should be having another podcast and a little bit more narrow topic, because your knowledge and experience is too it's vast. It's so big that we have to divide into small little things. But I really appreciate. And can you tell?
I would like to say that if anyone's interested in looking at our course series,
Yeah.
it's at www.glassmanseminars.com.
Yes. And when is your next courses? Is it going to be online, or it's going to be?
We're doing them live. I don't usually do well online, so it's September 16th and 17th.
Yes.
It's here in my hometown in Melbourne, Florida.
Okay.
It's at a beachside hotel. It's a gorgeous hotel right on the beach. It's kind of fun.
Could you give us a brief course? So it's gonna be like how many hours each day?
It's Friday and Saturday. It's two full days.
Okay.
It's a small group. It's no more than 15-20 people.
Okay.
And it's called TMD, occlusion and parafunctional control for the general dentist. And if you look it up online at www.glassmanseminars.com, there's a complete explanation.
With the 2-day course, how much information can we take home, and we can use it right away?
So
we have to take more. We have to take
more.
No,
the answer is absolutely not. I call it the last occlusion course you'll ever need.
Okay.
It never made any sense to me that you needed an occlusion 2 or an occlusion 3 or where you sit there at a desk and you sit there and play with models and you make ideal occlusions. That makes no sense.
Okay.
That's taking advantage of our need to be perfect.
Okay. I really appreciate that. That is something that I want to actually, maybe I'll see you September, right?
I would love for you to come. It's a fun, wonderfully practical. It's people get really upset with me. You're trying to tell me that you're going to teach all that somebody needs to know in 2 days. The answer is what they're already taught about TMD is so wrong in so many ways. That by simplifying it and making it The answer is yeah. You know, yes, I do a full year course, and you can do the full year course. It's not for the general dentist. That'd be crazy.
Okay.
No, you know, when you'll see that full year courses are online. They're not, unless you're really involved with pain management and you really want to do more than, you know, and I would take this first anyway. So don't even look at the year-long courses. Big faculties and major people and really good people I work with, international names, all great, but that's not for us. For the general dentist, this is really someone once said, I said, it's the last occlusion course you'll ever need to take. And someone wrote to me the other day, said, the only thing that course is missing that we should have is it should have a refund built in to all the other courses I took.
Okay. One thing I want to ask you, you mentioned that, you know, your classmate, the dean of the past dean of Pittsburgh Dental School was your classmate, Dr.
Great guy. Tom Braun.
Tom Brown.
Tom Braun was number one in his class.
Mm.
Number one. I mean, he made the rest of us look like dummies. You know, he was the kind of guy that when you went to when all of us were up pulling all-nighters to study,
yeah,
he was in a movie.
Wow.
He was good because he was studying all. I mean, he did it the right way.
Wow.
He was just number one. He is very particular. Goes on, becomes an oral surgeon.
Mm-hmm.
And I was like everybody else, somewhere in the middle of my class, trying not, hoping that nobody knew my name. So he goes on, becomes an oral surgeon, and he then eventually becomes dean at Pitt.
Mm-hmm.
I'm now practicing in Allentown, Pennsylvania. It's you know, I'm 40, so it's about 20 years ago, 25 years ago. He's now dean at Pitt. I get this call, Dr. Glassman, my staff, Dr. Braun's on the phone. That's fascinating. Great. Hey, Tom, how are you? Great. Good to hear. Hey, what are you doing? I'm in Allentown. I have Pitt going. He's telling me about it. And then he said, well, the reason I called, I thought you should know this. So what's that? And he said, apparently there's someone using your name, speaking all around the world in sleep and pain. I said, no, Tom, that's me. Went, no. Yeah. It didn't make any sense to him. I mean, I was not a top dental student for damn sure.
Wonderful story. You know, I'm sure you guys still keep in touch somehow, or
I saw him. He invited me up. I did a course there.
mm-hmm.
I saw him again on a weekend, but he has since retired, and I don't know if recently went through a divorce and got. So I've lost touch with him, which is kind of sad because he's was a really good guy.
We might invite you for the 20-year reunion at the class of 2003 and at Pittsburgh next year. Would you be a speaker for us?
I would. Oh, my wife is from Pittsburgh.
Oh wow!
We were there the years that the Steelers were becoming, from the years when Green first, Mean Joe Green first got drafted. So we were there all those Bradshaw years and the championship years, and we had season tickets, and and she lived in Mount Washington. We had a view of the city from our bedroom. Yeah, it's great. She's a Pittsburgh fan. She loves Pittsburgh. So if you told me that there was a reason to go to Pittsburgh, she'd be all over that. No, the answer is that I wouldn't be able to say no.
Absolutely. Thank you so much, Dr. Glassman, for the time that you spent with me. Even though I know you want to be rested, but I really make it happen. And so I appreciate your time, and I look forward to see you one of those days, either at your course or at Pittsburgh Dental School.
Sounds great.
You have a great night, and take care, sir.
Nice, you too.
Thank you again.